Hello, everyone, and welcome back to the Neurotransmitters. We are continuing our Chief Concern series with part 2 of neuropathy. I'm joined today by my co-host, Dr. Galina Geichman. Galina, how are you?
Hey, Michael. Thanks for having me back, and thanks for continuing the series. I'm doing well, and I'm excited to keep the knowledge and learning going.
Yes, and we have a return guest, Dr. Marcus Pinto from Mayo Clinic, our neuropathy expert here with us today. So, Marcus, thank you so much for coming back, and we really appreciate you taking the time to talk with us more about your expertise in this area.
Thank you, Michael and Galina, for inviting me back. Again, it's an honor to be here, and let's start.
Yeah, so Galina, fire us off.
So, Marcus, last time you were here, you gave us the complete landscape of neuropathy diagnostics, from the questions to ask in clinic to the initial testing that you should and should not send. And so we thought we'd actually focus a little bit more on management this time, kind of dive into, okay, so what? You've got the neuropathy, you've got the diagnosis. What can we do now? And how do you approach that in terms of, talking to patients about it, educating them, but also what are the various elements in our armamentarium for managing neuropathy?
Yeah, I think it's a good way to start because neuropathy can be very frustrating for patients and for doctors. So we as physicians, we want to make people feel better, and we want patient symptoms to improve. And when we're talking about diabetic peripheral neuropathy, idiopathic peripheral neuropathy, inherited peripheral neuropathy, we are talking about probably 3/4 of the causes of neuropathy. I would say that around 3/4, so 3 out of 4 patients with neuropathy, their neuropathy, you won't have any disease-modifying therapy available. So you won't be able to make them feel less paresthesia, less numbness, less tingling, and you're not going to be able to make their sensation to improve. So it can be very frustrating. And I think that it's very important whenever you first see a patient with neuropathy and you do the diagnostics, you diagnose them with neuropathy, you have diabetic neuropathy. And then you sit down with the patient and honestly tell them, say, hey, now you have diabetic peripheral neuropathy. And unfortunately, we do not have any magic pill to make your nerves to regrow, any magic pill to make your sensation to improve. And if you do have pain, then we're going to talk about neuropathic pain management here, which is another important topic to discuss because there is also so much frustration about neuropathic pain management for patients and doctors. And we're going to talk later. And then doing just general neuropathy education to the patient upfront is very important because whenever you set up expectations, so then the patient feels better, the doctor feels better, your patient physician relationship keeps going well. And that's the first part of when I diagnose someone. There's not very often that I'm the first neurologist who see a patient with neuropathy, but sometimes happens. And I sit down with them and explain just first part to them. Then after I do just general neuropathy education, it's also important to see, for example, are they falling from neuropathy? Do they have significant imbalance? So every patient who has falls and have a neuropathy, I think they should be seen by a physical medicine and rehab specialist, also a physical therapist to see, do they need a gait aid? What type of gait aid? Do they have a foot drop? Yes, or if they have a foot drop, they should be fitted for an ankle foot orthosis or AFO. So because that significantly impacts their ability to walk, that decreases falls, and falls can be very dangerous for these patients. And as a second thing that I always talk to them, depending on their degree of sensation loss, is care of the feet. So, the diabetic patients usually know better because endocrinologists are already educated on that they should always be looking at their feet every day, front, top, bottom, see if there's anything sticking to it. If the skin is very dry, use some cream, and a care of the feet, fall prevention, and general education of neuropathy, I think should be done in kind of every first neuropathy encounter.
So you bring up an excellent point, and it's something I probably see people as the first neurologist just because of the neurology density in my area for their neuropathy. And a lot of times it breaks my heart a little bit because they'll say what are you hoping to get out of this visit? It's I want you to fix me. I'm just I don't think that's in the cards for what we likely have available. And so it is like a lot of what you're saying, counseling them, managing those expectations, and talking about like what are our next, no pun intended, our next steps forward in terms of keeping them from developing any further comorbidities.
Yeah. And this is a very important part, Michael. And then I also talk with them about how to keep your nerves healthy. And then there is no specific diet for neuropathy. There is no specific supplement for neuropathy. It's very important to say out loud because given the frustration and the disappointment, there is a huge opportunity for people who want to steal your money, get advantage from you because you're desperate with just neuropathy no one can fix. So it's very important for the patient, the doctors to know that laser therapy doesn't improve neuropathy. Putting your feet into vibratory kind of devices do not make your nerves to regrow or make neuropathy better. Tense unit, scrambler therapy that may help with your pain, and we're going to talk about that in neuropathic pain management, but they're not going to make your neuropathy to improve. Okay. So, and then talking about comorbidities is very important, especially if you have diabetic neuropathy or metabolic syndrome associated neuropathy. And just before we go into, it's very important to say there is growing evidence that metabolic syndrome is associated with neuropathy. Mostly patients who have central obesity and also patients who have high triglycerides. So the triglycerides have been strongly associated with neuropathy. Now they are, hyperlipidemia, hypertriglyceridemia, central obesity, metabolic syndrome. They are considered risk factors for neuropathy. Okay, there is a growing concept, not very well accepted yet in the neuropathy world. Okay, that is something called obesity-related neuropathy, which is and that's why if you look at the pre-diabetes literature, right? And then there was even here where I'm from Mayo Clinic, then one of my mentors, Dr. Peter Jick, the father, was strongly against and even did a very nice work here showing that pre-diabetes doesn't cause neuropathy, which I think he's correct, but it's not the pre-diabetes, it's what accompanies the pre-diabetes, what comes together with the pre-diabetes, which is the metabolic syndrome. And I disagree with Peter on that. Peter did not specifically look into metabolic syndrome, but there is very strong evidence coming out from other places showing that obesity is in fact associated with neuropathy. And talking about diabetes, there's an important difference. Why? Because in type 1 diabetics, the DCCT and the 30 years of DCCT, for those who are not familiar, is the pivotal trial for New England Journal of Medicine, 1993, that showed that intensive glycemic control improves the microvascular complications of diabetes, prevents and also improves, and neuropathy is one of the microvascular complications. So then controlling the blood sugars does help preventing the neuropathy of type 1 diabetics, and also even can, some patients improve symptoms, in some other patients, and it can also slow the progression or stop the progression. But in type 2 diabetics, we thought this was the same, and it's not. So in type 2 diabetics, the evidence shows that the main driver is the metabolic syndrome. The hyperglycemia, yes, it can also have a modest effect in the patient developing neuropathy, but you probably have seen in your practice patients who have had an A1 like a 7 to 8 or something, they're not badly diabetics, and they develop diabetic neuropathy in just type 2 diabetics. And it is usually also because they have other comorbidities. They also have obesity and hyperlipidemia. So then the comorbidities we're talking about, the importance of managing also. So there is no like class A evidence, like a randomized clinical trial showing that managing obesity, losing weight, and also working on lowering the triglycerides improve neuropathy symptoms or slow progression. But there is good prospective research studies showing what I just said. So we recommend to every patient who has peripheral neuropathy and metabolic syndrome or diabetes that they should also work on their lipids with their primary care doctor. They should exercise. There is evidence, moderate degree level evidence that aerobic exercise can improve neuropathic symptoms or slow progression of neuropathy. So, usually people with neuropathy, because they have painful feet, they don't like to run. Some of them can't run. And also sometimes walking, the impact can make the pain worse. Walking not going to make neuropathy worse at all, but it can make maybe symptoms exacerbated and you can feel more. So, swimming, like yoga, that's a good one for even core. Yoga is not aerobic, but yoga can work with your core and your balance. It's important. So swimming and also cycling, the elliptical, those can be used as exercise for people with neuropathy. And we also talk about diet. And the diet that is good for your heart is good for your nerves. A diet balanced, in fruits, grains, lean proteins, avoiding junk food, eating vegetables, so everything that is good for your heart will be good for your nerve as well.
It's helpful to hear you say that as a neurologist and to give that counseling, because I think the same, that some of my patients have told me that, they get the diagnosis, but not so much the counseling. And I think we have a really important role to play, even if we're referring back and working in concert with our primary care colleagues to say like, hey, I really care about your diabetes, as much as your primary care does, and really sort of try to emphasize the need for that management. And I do think, while, as you said, frustrating that we may not be able to reverse it, I think I always try to tell my patients that we can slow the progression. If we can control the elements that are actually sort of the toxin to the nerve in this case.
Yeah, that's very much true. We can try to correct the metabolic crisis that is happening in the nerves and also in your whole body, and controlling these risk factors for neuropathy, also will hopefully, and in some patients, Galina, anecdotally, they say that the symptoms improve. They feel less the paresthesia, they feel less the pain. They feel overall they feel better. So I highly recommend that to all my patients. And we also talk about, that if they drink alcohol, also the alcohol is toxic to the nerve. We all know that. And some patients, for example, if they are drinking, there is no number for neuropathy, so we use the same number that usually in general medicine, which is you should not drink more than 2 alcoholic drinks a day. But avoiding alcohol will be good for your nerves. Of course, if you drink 8 beers a day, gosh, cut to 4. Maybe cut to 2, So like anything you can do, because a lot of people drinking is part of their life. Some people were sommeliers, they love wine and they love the taste and all that. So it tells them, hey, now try maybe there is wine without alcohol, but these wines are not good, especially for these people who love wine. But the beer, try of the 8 you drink. Maybe you drink 4 that's, 0 alcohol, or maybe all of them, try something too. So I try to give the power to the patient and tell them, empower them on what they can do, to prevent worsening of their neuropathy. And of course, if they don't have diabetes, like avoid as much as you can developing diabetes, also avoid gaining weight. If you can lose weight, it's also, this is usually, good for neuropathy. And there are very nice basic science studies done in rats, showing that, the obese rats, if they're put into an exercise program, they're put in a low caloric diet, it does reverse the metabolic problem in the axons and also in the neuronal cells and also in the Schwann cells. And so showing that there is very nice basic science evidence that kind of molecularly the change in the diet and the exercise, are impactful to the nerve health. So there is a nice research coming from University of Michigan, showing that. There is one of my colleagues for the Peripheral Nerve Society, Dr. Brian Callahan, Melissa Lafros, Eva Feldman, and also Stephanie Ide. They work with that. They put the little rats to do high intensity interval training, and and then they get like a autopsy, sciatic biopsy of the rats, and show this very nice evidence. So this education is very important.
Excellent. I know you mentioned there's no specific magic pill. I recall that some people, including myself, will recommend alpha-lipoic acid to some patients. What's your opinion on that as a vitamin supplement alternative kind of thing for especially like diabetic neuropathy?
Yeah, Michael. Yeah, for diabetic neuropathy, for sure, that's what we have the most evidence, So it was very promising alpha-lipoic acid, in the 90s and also the early 2000s, especially, in short term and especially the IV form. we don't use in practice. We use the oral, 600 milligrams the dose. So I discuss with them, Michael. I tell them about the evidence, and as there is not much we can do for neuropathy, a lot of patients start taking, especially those who like supplements, to improve their health. It's not harmful, and it's also quite inexpensive. They can buy over the counter. So I have several patients who take it, and it's 50-50. Some people say it makes no difference. Some people think it makes a difference. Whenever it makes a difference, you always wonder, could this placebo or not? But it's a very harmless placebo, So then I do not encourage them to take. I have like kind of a smart phrase that I discuss that. If they would like to take supplement, there is some evidence, that alpha lipoic acid would improve neuropathic symptoms and even, slow down progression of neuropathy. The evidence, they did a large trial at 4 years, and at 4 years they did not see a difference comparing alpha lipoic acid 600 milligrams daily to placebo. But also, whenever the trial is negative, you always try to find why it was negative, right? So every single study in medicine, and the patients on the placebo arm did not significantly worsen. And then there was a thought that they did not worsen, so maybe that's why there was no significant, because there was a difference, but not significant. It did not reach the primary endpoint, but reached a few secondary endpoints. So, so there is, say, some evidence. So it's not recommended by the American Diabetes Association. It's not recommended by the AAN, the big kind of diabetic neuropathy kind of guidelines. But I think it's reasonable, if the patient interested to take. And you can also sometimes, right, use the placebo on the patient's behalf, essentially. So anyway, so I have patients who take it, and I discuss that evidence with them.
No, excellent. Thank you.
Marcus, you mentioned that we've sort of been focusing a little bit on the diabetic neuropathy, which is, as you said, probably the most common. For those patients who have more of the sometimes genetic subtype, which often are not painful. I know they can be, but often aren't. Or the idiopathic, which can be painful or non-painful. But let's focus on the non-painful neuropathies. Besides the safety counseling around checking your feet, is there anything else you recommend specifically for those patients?
So for the non-painful neuropathies, the general education, the care of the feet, the balance, the need for AFO, especially for the inherited, because CMT patients, almost all of them are going to have foot drops.
Yeah.
Some of them also of course, I always check the vitamins of my patients, with neuropathy first encounter. I check vitamin B1, B6, B12, folate, and copper, essentially every patient. I also like zinc. So the ones I said, B1, folate, B12 with methylmalonic acid, and copper and B6, they can be associated with neuropathy. Copper and B12, copper more of a large fiber, B12 also more of a large fiber, also both can cause subacute combined degeneration of the spinal cord, but they can also cause some small fiber symptoms and small fiber damage as well. So these 5 ones that I said, they can cause. Zinc is not associated with neuropathy, but zinc, in a poor man's world, I think zinc is a nice parameter of your nutritional status. So I think zinc is a sensitive mineral, to be deficient if you are malnourished. At least, there is some evidence on that, and also in my experience. So I like zinc to also, because, for example, if I see someone who I suspect may have a nutritional neuropathy and all of them are normal, including zinc, I said, it's likely not nutritional, because there is a lot of questions regarding the thiamine, right, assays, especially for Wernicke's encephalopathy, for example, right? We know from textbooks and also from, some kind of a real world data that some patients with Wernicke's encephalopathy are going to have a normal thiamine on the available assay. So, but for nutritional neuropathy, that's why I usually if I suspect that, a more broader panel. But and then when the vitamin, when any of them is low, of course, if it's B12, for example, is low, right? And I always like to confirm methylmalonic acid, especially those they're like kind of in the low normal range, So, but then whenever they have a low vitamin B12, I usually also, our panel here will include getting the antibodies for pernicious anemia, and if they do have pernicious anemia, it's a lifetime subcutaneous B12 replacement. If they do not have pernicious anemia, Usually, and I believe the neuropathy is secondary to B12 deficiency. Usually, I supplement with subcutaneous B12. I do the protocol we do here, which we do like 1 milligram daily for 7 days, then weekly for 4 weeks, and then monthly for 5 more months. After that, I transition them to oral B12 for the entire life. If they have low B6, low folate, depending on how low it is, I usually just give them a general multivitamin, okay? And I usually tell patients, this is an important point, do not buy the fancy multivitamin, vegan, paleo online. Don't do that. Buy the off-the-shelf ones, okay? At the supermarket you want, okay? But buy off the shelf. I'm not going to be mentioning names here. Don't have any kickback, anything, but I'm not going to be doing that. But the general ones, they are well balanced. Okay. And the thing that's important, patients should see, they should never take more than 50 milligrams of B6 a day. That's another very important point. And also those who like to work out, people who like, oh, I like to work out. I like to feel high when I work out. Gonna the pre-workouts. These pre-workouts, some of them, and also some energy drinks, they have high content of B6. Okay. So there are several cases reported of people who develop B6 hypervitaminosis, B6 toxicity from energy drink and pre-workout powder. So be careful with that. And also those who bought super vitamins online. Okay. So you should never take more than 50 of B6 a day if not directed by your physician.
Oh, that's great. I know when I was a fellow, I was working crazy hours and I was having to drive at night a lot. And I was drinking like 1 to 2 5-hour energies a week. And I realized like halfway through the year, I'm like, oh man, these have I forget, somewhere between 200 and 400 milligrams of B6. I'm just
It's crazy. It's crazy, Michael. It's crazy, and you have no idea only if you check.
Right.
So then, and the B6 also business, just to talk a little more about that. So usually when the B6 is, it's very high, usually above 400, 500 in the serum assay. So when it's associated more of a large fiber sensory neuropathy picture, okay, can also cause, of course, as a sensory neuropathy, small and large fiber dysfunction, but it's more of a sensory neuropathy picture. So the high B6, it's a little controversial if it can cause kind of a chronic length-dependent peripheral neuropathy. It's usually more of an acute, subacute onset sensory neuropathy. But of course, if you have neuropathy, you don't want the B6 to be high. So patients ask whenever they come to see us and they have a chronic length-dependent neuropathy, a dystosymmetric polyneuropathy, we check the B6 and come back like in the hundreds, 180, 200s. They ask, was this damaging my nerves? We say, we don't know. But I think helping was not. So let's change this multivitamin. Let's stop that and get one that will have kind of a more normal, but lower levels of B6. And most of the general ones, like off the shelf, they have 2, 4, 6 milligrams of B6. So it's a very balanced, kind of a good quantity.
Marcus, you mentioned copper, so I want to ask you a question I've been wondering about. I know the teaching is, that copper deficiency can cause the same type of presentation as a kind of like a myeloneuropathy or subacute combined degeneration. And I'm curious, I've seen a couple of cases where people come in with these, almost what I would call almost like a small fiber, kind of like scintillating paresthesias. And then lo and behold, copper comes back a little negative. Have you seen that? Do you replete the copper there? What's been your experience?
Yeah, no, yeah, that's a good question. So usually, my experience, copper deficiency neuropathy, myelopathy is very rare. So when the copper is just mildly low, it's not copper deficiency neuropathy or myelopathy. The copper used to be like substantially low. And I would say probably maybe 30, 40% lower than the lower limit of normal, something like that, kind of significantly low. And then whenever that is, the protocol, here, there is a neurologist here, Mayor called Niraj Kumar, who I think published, the few kind of, in the first works on copper deficiency myelopathy. And we have a protocol that we do, and we do copper like 8 milligrams for 1 week, 6 for 1 more week, 4 1 more week, then 2 lifelong a day. But unfortunately, these patients do not get much better. So, it's an interesting, I think, disorder, they do not get much better, but some of them do get a little better, and usually it's more clear when they have the correct phenotype, which is a kind of a dorsal column myelopathy and also a sensory neuropathy. Okay, if they only have small fiber symptoms, no large fiber, normal EMG, it's hard to believe that this could be copper deficiency. But again, this could be, for example, multivitamin deficiencies. Okay, I have seen several patients with nutritional neuropathy, not only copper, but also, and that's why usually, Galina, I order all these vitamins. Oh, you're crazy! You order so many tests. Yeah, I order them. So I can't say I'm crazy. But I feel that getting like a full panel of vitamins, I also do vitamin D, vitamin A, vitamin E, because then, you have a better understanding of what's going on with the patient metabolism. And that's not only one vitamin, there are usually multiple vitamin deficiencies causing, the patient symptoms.
Yeah, I had a sad case of a patient treated for scurvy, and her neuropathy was attributed to the vitamin C deficiency. And I was like, I think it was the other vitamins that were also
Exactly.
gone. Like there was no B12 in that serum, and she, upon, digging into the records, did have pan essentially
Exactly.
deficiencies, but it was helpful even for her in our conversation because she's like, I don't understand how this happened. I read up all, I chatted with ChatGPT and it doesn't fit. And it was, doing a little bit of counseling around the severity of her nutritional deficiencies at the time.
Yeah, that's very important.
So I think we need to talk about the elephant in the room, right? So, everyone's always like, a lot of times when we get the patients coming to us, they've been told, here's your gabapentin, go see neurology. And it works, it doesn't work. Sometimes its dose isn't quite right. So what's your approach when we do have someone with a neuropathic pain, diabetic related or not? What's your approach if they're coming to you kind of, blank slate as far as your opening moves?
Yeah, Michael. Yeah, that's a great question because it's so common. And I always also start with counseling, So I tell them, say, hey, you have neuropathic pain. Neuropathic pain is different than essentially all other types of pain. And why? Because if you have a headache, you take Tylenol. If you have migraine, you take Max out, and your pain goes away. The pain goes away. But neuropathic pain doesn't go away. You have a shoulder pain, Tylenol, take some Toradol. Oh, put some cream. Oh, great. My shoulder is feeling well. Have no pain. So our brain is wired that if you have pain, the pain needs to be fixed. And that's why neuropathic pain drives everyone crazy because it doesn't go away. You go to the doctor and the doctor gives you a medicine who causes you all sort of symptoms, and doesn't fix your pain. So we want our pain fixed. And whenever I see a patient that has never started or if it's already on a medication or improving, I do this type of counseling and say, hey, the clinical trials, the outcome, the primary endpoints of a clinical trial, which is this drug work or doesn't work based on that number, they were 40 or 30% improvement of the pain. We're not talking about resolution of the pain. We're talking about 40 or 30, and the most recent ones were 30%. So this is very far from 100. 30, okay? So then I tell them, say, hey, and this is not fixable. We will work together to try to get your pain under control, get your pain under an acceptable level. And I also ask them about their mood, anxiety, and sleep, okay? Because if you do not rest at night, if you have undiagnosed OSA, or that you have chronic insomnia, you're going to have more pain because the brain amplifies the pain, okay? And I always talk to them also in my general spiel. I talk to them about, hey, when you go on vacation, what happens to neuropathic pain? Most of them will say, I feel less pain when I go on vacation. And I say, well, I can't prescribe you a vacation, but it's important for you to know that it's because your brain is able to block the neuropathic pain signals going to it. And the brain is very powerful. And I always also introduce to them this concept, for them to understand that how come the brain can amplify or the brain can block the pain signals because it's very important for them to know. And so I always do overnight oximeter test to screen for OSA. I always ask about mood and anxiety, which is usually it's a problem in people with pain because they have pain. So they're gonna be anxious and they're gonna feel sad about it. So and it starts with that. And then I usually so the evidence shows to us that we have four classes of drugs to work for neuropathic pain. We have the gabapentinoids, gabapentin and pregabalin. We have the tricyclic antidepressants that we usually don't use that much nowadays because of the side effects, especially with the elderly and all that. We have the S-duloxetine and there's venlafaxine and venlafaxine, and we have the sodium channel blockers, okay? Carbamazepine, oxcarbazepine, lacosamide, lamotrigine. These four, they work. And I try to see in the patient comorbidities, their age, their lifestyle, which one would be the better one for them. If they come to me and they're anxious and depressed, so I usually start with, duloxetine. If they come to me, their mood is good, they're just a little anxious, and a lot of people also, it's important to ask, I always ask, have you been on antidepressants? Because a lot of people have strong opinions against antidepressants. And you guys always probably, of course, know that. So, and anyway, and it's very important to disclose that the medication you're giving them is an antidepressant because they can get mad at you if you don't tell them and then they find out later. And duloxetine and the SNRI is very important to also disclose the risk of suicides, that can happen with that. Say, hey, so I'm having weird thoughts, let me know. But I usually try to see if they have epilepsy, so then, the sodium channel blockers, would be great because they're great anti-epileptic medications, Lacosamide, for example, I think is a promising drug for neuropathic pain. Insurance a lot of times doesn't approve, because it's expensive and all that. But it doesn't come with the problem of lamotrigine, which is a wonderful drug, but the up titration is so hard for many patients. And oxcarbazepine and carbamazepine cause, hyponatremia, right? And especially in the older folks. So I try to see based on the patient comorbidity and during the encounter what I feel about them, and then I offer one of them. And then when you offer again with that, hey, my goal is to improve 30%. We're going to up titrate the dose, okay? Whenever you reach the 30% at part of the up titration, they tell them, say, hey, you can probably stop, and at the up titration. And then whenever we see the patient back, and then we could discuss again, continue going up, okay? I always tell them, say, hey, this is not like a 1 or 2 day thing. It will be like a 6 to 12 week process. You should not give up on the medication too soon. Even if you have side effects, try to push it through a little bit. Okay, of course, if you develop hives, anaphylaxis, sure, stop right away, go to the ER. But if you develop some dizziness, some kind of a stomach ache, some mild issue, hey, keep going because, we should not fire one of these medications prematurely. Because first we don't have many, and second we want to give you the best shot at all these medications. That is also, continuing on this. So whenever they improve 10, 15%, you got to the maximum tolerable dose. So there is very good research showing that combination therapy is very helpful. Okay, especially of SNRIs and gabapentinoids. Okay, so they usually are my go-to. SNRIs and gabapentinoids. I usually reserve sodium channel blockers for folks with epilepsy or for folks who have very refractory pain or folks who have pain that's more kind of like a neuralgic or kind of a jolt type of pain, like trigeminal neuralgia, right, of the legs and hands. So these patients sometimes can do better with sodium channel blocker. But that are the two classes I usually use. I very rarely use TCAs, the tricyclics nowadays. I don't remember last time I prescribed. But all of these four classes, they have good evidence. And the combination therapy, you can do 2 or even of 3 drugs later, but each of them improving the pain some amount.
No, that was a great rundown. And I'm really glad you talked about the combination therapy. I find that you do find, like, you have these people who the first sign they take it a day or two and then they just say, I don't feel good, and they stop taking it. And I think we see that with almost any neurologic condition, whether that's, neuropathy, seizures, migraines, fill in the blank. And it is that counseling, like laying the groundwork for that, really, gets them to, steel their loins, if you will. And it's really important. nothing is a quick turnaround. So I appreciate you emphasizing that point today.
Yeah, I just wanted to add, Michael, that it reminds me of our conversation around like headache management. Like how many minutes into the headache are you taking, the sumatriptan? And same with the neuropathic pain agents. I think some of my patients, whether due to understanding or probably my miscommunication, maybe take a PRN, like you were saying, like the shoulder hurts and I take an Advil and the feet are tingling and I take a gabapentin, and trying to counsel them on the regularity. And then also small adjustments. Like I sometimes find, I usually recommend duloxetine in the morning because it's sort of activating, and some of my patients taking it at night and then having trouble sleeping. So even a switch of, hey, let's move it to the morning, maybe then this can become a winner. Vice versa with the TCAs doing it at night because they can produce a little somnolence. So trying to do this kind of like little adjustments and little tweaks in addition to the up titration around the timing and optimizing for them.
Yeah, that's very important. Try to use the medication, the side effects pro-patient, right?
Yeah.
So that's very important to counsel them. And whenever I think you do good counseling, I think you have better outcomes, with the patients. Because if they know that they should continue taking and not stop it early, they will try though, and you're partnering with them to achieve the better outcomes possible. Anyway, and also one very important point to say is to not take opioids for neuropathic pain. There is very strong research showing that opioids for neuropathic pain only work in the very, very short term. In the long term, it worsens pain. And this drives patients nuts because in the beginning that was helping, but then their pain just continued to worsen. So opioid causes what's called opioid-induced allodynia, opioid-induced neuralgia. So the pain worsens, the neuropathic pain worsens on opioids, which in many other disorders that doesn't happen that much, but in the nerve pain that does happen. And people also sometimes ask about topicals. What topical can we use? So I usually only use topicals for those who have pain only below the ankle, or the pain concentrates more below the ankle. And usually the topical, I usually try them to try first is the lidocaine 4% cream over the counter. So they get off the shelf and they try it on their feet. To see. And I usually tell them, those who have a lot of pain at night, I tell them to do like a foot routine. That every day before going to bed, they soak their feet in lukewarm water with an Epsom salt. And it's an important thing. If they do that, they should not discard the Epsom salt like the water on a sink. They should do it on a toilet because the Epsom salt can clog the sink. And so that's important to say. A patient of mine complained about that. So, okay, good. So then I started saying that. But doing that for 30 minutes, soaking the feet. And then after that, they dry their feet. They put some cream, some Veni cream, some lubricant, and then they apply lidocaine, in the feet and go to bed. That's usually helpful. Some people and some places, here in our institution, we have a triple cream that they combine. It's a compound cream. They do amitriptyline, ketamine, and gabapentin cream that also some patients like, but it's expensive, because the compound insurance does not cover. And now there is an FDA-approved therapy for neuropathic pain. It was main diabetic, but they've seen insurance approving for diabetic, non-diabetic, which is the capsaicin 8% patches that they use like 4 times a year. Need to go to a pain medicine office. They put on the feet for 30 minutes. And there is also some patients with some good results with that.
How's that experience for patients?
Well, some patients, it worsens in the beginning.
Yeah.
Because capsaicin will deplete the substance P neurotransmitter, in the down in the nerve. But some of them have improvement, and then even the pharmaceutical company data, right? So I have like 2 pages on that, and both of them they're still doing, so they like it. Their data say that 70% of patients keep using, after 1 year.
That's fascinating.
Yeah. So anyway, so I think it's another resource for those with refractory neuropathic pain, and also for those that they all should go to a pain doctor, I think neurologists should try to manage them with medication, but there is also FDA. I think it's FDA approved, but the spinal cord stimulator for diabetic, painful diabetic peripheral neuropathy, But patients usually try to shy away from spinal cord stimulator because it's a procedure, it can have complications and all that. But whenever your patient has a refractory neuropathic pain, I think asking a pain medicine physician to see them, I think is recommended.
Excellent. I would like to get your opinion in the last couple of minutes we have. Gabapentin, I think, is, right, everyone knows it as like the nerve pain drug, even lay people. In terms of dosing, I find that that's probably one of the more misunderstood medications we have in terms of like frequency and how high to escalate it before transitioning to something else. What's your general approach in someone who's, let's say, coming to you, who's maybe only on 100 or 300 milligrams 3 times a day and having an ineffective response?
Yeah, that's a very common issue, in the office. So I think usually I usually start when I got gabapentin, depending on the patient's age. So if they are like kind of a below 70, I usually will do like if the pain is severe. Okay, if the pain is severe below 7, I usually start with 300 once a day, and I up titrate every 3 days. So, but if there's an older person, I do 300 every week. Okay, and with 3 times a day, that's I think the posology should be done. And the question is, where do you go? Where up to how much you go
Right.
before you switch? So usually, okay, if the person is below 70, normal weight person, not like a very skinny 50 kilograms person. So I usually go up to 2.7 grams, so 2,700, to see if there is any improvement. If they do feel there is improvement, then usually go to 3,600, which is usually the maximum use. I've used it more for folks who have felt significant improvement, all the way along. I have no side effects, but usually I think that if you do not see improvement at 2.7 grams, like no improvement at all, they say it's just like sugar, for like a younger than 70-year-old person. And if they're older than 70, usually go to 1.8, like 1,800 a day. If there is no improvement at all, usually I would either switch to Lyrica. I would switch to Lyrica if they're interested, or I would try another agent, But this is the literature. This is kind of to be defined. The clinical trials, of course. Whenever you do a clinical trial, you have the clinical trial team. This infrastructure is so different than you yourself and your patient, maybe a nurse to help out, So, but usually they need to go to 1,800 or more for you to say, okay, there was no benefit at all. This is my opinion.
Yeah, no, I would agree 100% with that. I find the biggest, right, it's that bioavailability per dose with like the escalating doses, where you just get a lower and lower percentage of what you actually take in. And that's been my experience as well. So I'm glad to hear that it's the same across the board.
Yeah, no, yeah. And one thing that I do know, and people also know that, but it's important to say that gabapentin and Lyrica, they are, very similar molecules. So if you want to switch a patient due to side effects like brain fog, dizziness, imbalance to Lyrica, you can divide the gabapentin dose by 6, and then start them on the same dose of Lyrica the next day.
Perfect. Gotta love those fast transitions.
Well, Marcus, thank you so much for another whirlwind. I feel like I learn something new from you every time. And it's actually really cool to hear someone like yourself who does this day in and day out, because it gives some reassurance to me. Like I've never heard kind of those numbers, but that's kind of what I've been doing. And it's nice to know that, I've been sort of doing it at least right according to Marcus Pinto, which I think in my opinion is a sufficiently high caliber. But I really appreciate you giving us that overview for the metabolic neuropathies, for the most common diabetic neuropathy management, and idiopathic as well, and touching on PT, on AFOs and AIDS, and then also most importantly that neuropathic pain and what we can do, even amongst the many things we can't.
Absolutely. Thank you so much, Marcus. Really appreciate it. And if people want to find you online, where should they check you out? Where's the best place to track you down?
Yeah, so I usually, the only social media I use for neuropathy related work is my Twitter. So Marcus V Pinto on X. So find me there, can ask me questions and all that, and I'll do my best to respond.
Thank you so much. And you can always find us on X also at neuro_podcast, and our past work at theneurotransmitters.com. Thank you everyone for listening, and we'll catch you all again next time.